Welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. Hear about chiropractic research from the authors in plain English, not through the media nor a middleman. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I'm an associate clinical professor in the Department of Kinesiology and Health at Miami University, and I'm also a chiropractor in private practice in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. Today, I have the privilege of interviewing Dr. Geoff Outerbridge. But before we get to the interview, I wanted to thank all of you who have subscribed to Chiropractic Science, and I'm especially appreciative to all of those who have given reviews on iTunes. iTunes reviews really help get others to find out about chiropractic science. So if you like the show, please take a second and write a review. It will support chiropractors everywhere. I'd like to share a review by JMVDC, who says, "Excellent podcast. What a wonderful accompaniment to my 10K runs." Well, thanks for that review, JMVDC. I've had a lot of people tell me that they like listening to the podcast as they exercise. And I think that's a fantastic idea. Why not get the benefits of learning as your brain is getting primed by exercise? So very good. Thanks again. And I look forward to sharing your flattering iTunes review in a future podcast. Please consider making a contribution to Chiropractic Science to keep these podcasts going. You can do so on our website at chiropracticscience.com, either by making a donation or purchasing the evidence-based patient education slides presentation. We are on social media, including Facebook and Instagram, so please connect with us there. In addition to iTunes, you can also listen to the podcast episodes on YouTube, Spotify, and your favorite podcasting app. All right, on to the show. All right, well, let's get on to the interview with Dr. Geoff Outerbridge. Geoff Outerbridge received a bachelor's degree in human kinetics and a master's degree in neuroscience from the University of Guelph. He began his career working for the University of Waterloo with the Ontario University's Back Pain Study, a research study examining the causes of back pain in industry. In 1996, he started an ergonomics consulting company to offer his knowledge and experience to clients in a wide range of environments, including mining, assembly line, and office work. In addition to ergonomics consulting and running a personal training business, he attended the Canadian Memorial Chiropractic College, from which he graduated in 2001. From 2001 to 2011, Geoff owned a successful multidisciplinary health clinic in Ottawa that integrated chiropractic, massage therapy, acupuncture, naturopathy, rehabilitation, and family medicine. He sold his practice in 2011 to join World Spine Care, an international nonprofit organization bringing sustainable, interprofessional, evidence-based spine care to underserved regions of the world. He moved his family to Botswana to establish World Spine Care's flagship clinics in Botswana, returned from Botswana in 2013, and has remained with World Spine Care as the clinical director. Geoff has established and continues to supervise World Spine Care clinics in Botswana, the Dominican Republic, Ghana, and India, and develops new projects in other countries. He continues part-time in clinical practice at Integrative Healthcare Collective in Ottawa. For full disclosure, I should say that I am a founding member of World Spine Care and continue to support it each year, and I encourage everyone to provide their support as well. I'm excited to have you on the podcast today so we can learn a whole lot more about the research that's being done at World Spine Care. So, Dr. Outerbridge, thanks so much for coming on the Chiropractic Science podcast.
Thank you very much for the invitation. I'm looking forward to it.
Yeah, so let's get started with just some basics and some historical facts. How did you become interested in becoming a chiropractor?
Probably not the conventional route. I never really had chiropractic on my radar through my undergrad and graduate studies. I sort of, grew up thinking that chiropractors were quacks and never really just thought about it. And then after I finished my master's, I started the ergonomics consulting business and eventually moved in with some chiropractic students who were studying at CMCC. And before, like as I was going through school, I kind of knew what I didn't want to do. I knew I didn't want to do medicine. I didn't want to do physiotherapy. At that time, physiotherapists couldn't diagnose, and that didn't really, I wanted to be able to diagnose. And I couldn't, I liked teaching, but I didn't want to teach. I liked research, but I didn't want to do research full time. So I just really didn't know what I wanted to do. And so I moved in with these chiropractic students, and they started asking me a lot of questions about neuroscience because of my master's, and asking me about ergonomics because of the consulting business. And I finally started to ask them about chiropractic, and it wasn't long before I kind of realized this is exactly what I've been looking for. And so I had just finished paying off all my debts from my undergrad and my graduate studies, and jumped right back into debt and started at CMCC in 1997, I guess it was. So yeah, and then realized, okay, so this isn't the profession I thought it was, and I've just loved it ever since.
Oh, that's pretty awesome. So can you tell us a little bit about the practice that you still have in Ottawa? I'm assuming that you've had it throughout World Spine Care, or maybe you can just tell us.
Well, I owned the clinic in Ottawa for 10 years, and then I actually sold that practice, and we basically liquidated our lives. We packaged everything into a container. We had sold our house and really just kind of hit the road, not sure when we were going to come back from our travels. So the clinic wasn't mine anymore. So after 2 years, we finally realized that it was time to come home, and we didn't really have another project where we could take the whole family. So we decided to come back to Ottawa, and at the time I was still working very full-time with World Spine Care, but I didn't want to, I wanted to continue with clinical practice, because obviously with World Spine Care I was running the clinic, so it was continuous clinical practice while I was there. So when I came home, I was able to join a practice very part-time. I was just working about 8 to 10 hours a week, just seeing a few patients and keeping my fingers in it, and actually using the World Spine Care documentation and database and all the stuff that our clinicians were using in the field, so I could really keep up with what they were doing and make sure I still had that really intimate knowledge with the documentation and database. And I continued with that, and I still have, but as I've pulled back from World Spine Care and taken on a more focused role, I've been able to increase my practice a bit. So when I started with World Spine Care, I was very much trying to do everything. So marketing and websites and fundraising and all the clinical work, and it was just all sort of consuming. But as more people have come on with the organization, I've slowly focused down into just leading the clinical program. So now I have more time, and I've expanded into about probably 25 to 30 hours of practice now. And actually the clinic I'm working at now, the owner of that clinic and I are opening a new clinic in October together. So I'll be back to actually being an owner again in October.
All right. Very, very good. So how did you become interested in or involved in World Spine Care in the first place?
Well, I knew nothing. I hadn't heard about it, knew nothing about it, but I was friends with Dr. Simon Dagenet, who had worked with Scott for a long time, and many people would recognize his name from a lot of research that's been done. And we became friends, and he came to Ottawa one day and met me at my practice, and we just got talking about sort of what was new in our lives. And after I told him what was going on with us, I asked him what was new with him, and he said, well, Scott's planning this thing called World Spine Care, and he wants to kind of bring spine care to developing countries. And it was really this sort of wait a second, stop moment, because I had applied for international development work when I was doing ergonomics, and it's something I've always wanted to do. I come from a family of missionaries, and my grandfather lived in Japan for 40 years, and my uncle was an orthopedic surgeon in China for 13 years. And so I kind of grew up with this ethos of service, and so it's kind of something I always wanted to do. But once I got into chiropractic, I kind of put that away, because I thought, like everybody else, who cares about back pain? It's not a big deal. How little I knew. And So when Simon came in and told me about this, I was like, wait a second, tell me more. And so he kind of gave me a general outline, and at that time, that was 2009, around August 2009, and I really didn't, it was totally out of the blue. So he told me about it, and I said, look, I'd love to do this for so many different reasons, and do you need clinicians? And he said, well, yeah, we're just getting started. We definitely need clinicians, and I think you'd be good. So I'll tell Scott. And I said to Simon, I said, I just have to go and talk to my wife Sophie about this, but I'm sure she'll be on board because she's very adventurous as well. And he said, okay, I'll get back to you. So he talked to Scott, and I talked to Sophie, and everybody said, great, let's go. And in October, I went down to the NAS conference. I flew down to San Francisco to meet Scott and Simon, and it was my first time meeting Scott, and it literally was, hi, nice to meet you, let's get to work. And we went up to the hotel room that he and Joan were staying in, and we just sat down and started to lay out a plan, and that's sort of when it all began.
Wow, that's really cool. Hi, nice to meet you, let's get to work. I love it. There's nothing like getting down to work. So that's great. Now, we're certainly going to be talking about the research that World Spine Care is doing, but I also just want to get a sense of the totality of what World Spine Care is. And so I guess a few points to say. First, your work with World Spine Care has resulted recently in a tremendous amount of research productivity in European Spine Journal. But you also were the lead author on a paper from Journal of the Canadian Chiropractic Association, which is basically seemed to me as an introduction to World Spine Care and gives us that sort of totality of what World Spine Care is. So why don't we start with some information that came from that article and just your overall experience about World Spine Care. For anybody who's interested in reading that, it's Journal of the Canadian Chiropractic Association. It's December of 2017. So perhaps we can just start with the kind of the big global question of what is World Spine Care?
Okay. Well, World Spine Care was this vision of Scott Haldeman's to bring spine care to underserved regions around the world. And that's really what we talked about at the very beginning. And as it evolved, we kind of really started to focus down on a mission statement that has three really key pillars. So it is bringing evidence-based, integrated, sustainable spine care to underserved regions around the world. And everything that we do fits inside of those three pillars. So evidence-based, we're using evidence to guide our assessment and treatment of patients. We're also gathering evidence to prove the efficacy of what we're doing. So evidence sort of in both directions with using it and creating it. And within evidence-based, it's patient-centered and using best available evidence and clinical wisdom and all those other elements of evidence-based. With integrated, we are actually integrating our services within existing healthcare systems. So we're not operating in silos. We're not just hitting the ground for a few weeks and taking off. We're actually building long-term presence on the ground. So in the first project in Botswana, and this is the same with all of them, we engage with the government. We get their support, and they provide a lot of what we need to open and run the clinics. So usually space, staff, equipment, housing, all sorts of things the government will provide, and then we bring the clinicians in and create these clinics. So we integrate them within the healthcare system. So we're working with medical doctors and orthopedic surgeons and trying to sort of slowly create referral lines within the healthcare system. And sort of create a two-way knowledge transfer where we're sharing information with the local healthcare system, but then we're gathering information from them to help us provide better care, whether it be with local endemic diseases or information about culture or just anything that we can gather from them. So that's how we're sort of integrating it within the system, and eventually, hopefully providing services all the way from very primary remote contact all the way down to tertiary care. So that's how the integrated part. Now, the sustainability part is really big. So we initially go in and we create this long-term presence in the clinic. So the idea is we set them up, we keep them running until eventually they can be taken over by local clinicians. So along the way, we're building capacity where we are educating local healthcare providers and patients and health administrators and so on. We're also, through several chiropractic colleges, so Anglo-European Chiropractic College, Logan, CMCC, Palmer, and National, they've all offered scholarships through World Spine Care for local students to come and train as chiropractors to eventually go back and take over these clinics. So eventually we hope that these clinics will be locally run, and the first two scholarship recipients have now returned to Botswana. One went to CMCC and one went to Palmer and are now working with our team in Botswana. So we really don't want to start these clinics unless we have this full exit strategy where we can actually leave it to full local control eventually down the road. So we also have a fellowship. We have fellowships that we've offered to train spine surgeons. One was through the Ankara Spine Institute in Turkey with Dr. Emre Asarajlu, and Christian Eder with the Swiss Spine Institute has also offered a fellowship. So we're trying to also build capacity at the tertiary level as well, and really throughout the healthcare system. So, and the third thing that we've been offering is we've had 3 spine care conferences in Botswana, so trying to help educate the broader healthcare community within the countries. So that's sort of the sustainability part of it. So we can have, again, there's this evidence-based, sustainable, and integrated. And so that's kind of the overview. We started so it was originated in 2008. That's sort of when it was first registered. And between 2009, when I got involved, and 2011, Scott and I worked on developing all of the clinical protocols, so all the documentation and database and things like that. And then in 2011, the Botswana government was ready for us to actually hit the ground, so I moved my family there for 2 years and spent that time, again, sort of establishing the clinic, treating the patients, and really learning, adapting, and modifying all of what we call the toolkit to local needs, but also making it adaptable to other cultures as well. Always trying to think of how can we create something that's applicable in all different countries. So we've had some unique challenges in trying to create things that are universally applicable across cultures. So that's what we've been doing. And then since I left, there have been all kinds of other clinic supervisors. So we have volunteers that run the clinic for a year or more. Those are our clinic supervisors. This is how we maintain that sort of sustainability or develop the programs until it's taken over by local control. It's volunteers. So we have clinic supervisors who come for a year or more to run the clinics. And then we have volunteer associates who are licensed clinicians who can come and spend anywhere from a month to 3 months helping out in the clinics as well. So that's how we've been able to maintain this on-the-ground presence. And those clinicians over the years have been remarkable in helping us further refine and adapt our toolkit. And along with our research team, we have a very large research team, and they've been involved in helping us as well. So it's sort of these clinicians trying to get things to work on the ground, and then the researchers trying to help us in what data we want to collect and how we want to collect it and so on. So it's been this real nice sort of collaboration between clinicians and researchers that continues through all the research and data collection that we do. Yeah, so I hope that's a good enough overview.
Yeah, that's a terrific overview, and it sounds like a tremendous amount of foundational work that went into putting this together and then bringing it to the Botswana government. And I'm curious, but I'll perhaps save this question for later, maybe just have you think about it as we continue to talk. But I wonder how that would play out, your experience in dealing with governments, how we can use that kind of knowledge that you've ascertained here and bring spine care, to the forefront of I guess, first world countries where, or developed countries, maybe is a better word, where, spine care does exist, tends to be expensive and maybe not the best evidence-based spine care either. So I'm sure maybe you can give us some pointers on that later, but I just wanted to say how much, after listening to all of this, how much effort it must have taken to develop these clinics.
Yeah, and it's a huge team. So it's been 10 years and a massive team of people who have all contributed to it, from clinicians from all different backgrounds and researchers with all kinds of specializations and expertise. And Scott really, I think, is the only person who could have done something like that and brought together all the real important stakeholders in spine care and put them at the same table to solve this sort of global issue. It's been remarkable in how he's rummaged up support from in all different sectors. So it was pretty easy to bring the chiropractors on board, and we're endorsed by all the sort of major chiropractic organizations, but also we're endorsed by all the major spine organizations around the world as well. So Eurospine and NAS and a lot of surgical organizations, surgical spine organizations, and to pull together that sort of support, which shows the sort of interprofessional collaboration of the organization, is something that, absolutely remarkable, that only someone like Scott could have done.
Yeah. Well, he's an amazing individual for sure. And we're very lucky to have him and have him continue to contribute to our profession, no doubt. So I'd like to continue on with World Spine Care and ask you some other questions, in particular, since the podcast is about chiropractic science. I'm interested in finding out more of the role of the chiropractor in world spine care. So on the ground, in the clinic, what does the chiropractor do? What are they in charge of? How do they communicate with the other professionals, et cetera?
It's a good question. So the role of the chiropractor is quite central in all our clinics. So in order for us to run a clinic, the person who's running the clinic has to act essentially as primary contact for spinal disorders. So we've all been talking about the primary spine practitioner. That's essentially what we're looking for, and who's running the clinic. So straight out of school, that's chiropractors. And so essentially all of our clinics are run by chiropractors. The vast majority of our volunteers are chiropractors. Now, the exception is in India, our project is actually at a school of physical therapy, and the clinic is run by a physiotherapist. So it's different because the scope of practice is a little different there. But in all our other clinics, it's the same scope of practice we have most places. Now, what's interesting is, so the primary spine practitioner is acting as that first contact. So they're running a clinic like you can imagine anywhere in a high-income country. They're also responsible for basically running the World Spine Care program there. So they're not just treating patients, but they're collecting data. We have a data registry that gathers demographics, presenting complaints, diagnoses, and outcomes, and that data has to be very well managed. And so we have a sort of user guide for our toolkit. It's kind of like a detailed research protocol for exactly how we're collecting the data, how that data is getting into the database, how that data is being managed, and quality control and all that sort of stuff. So they're responsible for that aspect as well. But they're also responsible for the residents, for picking up volunteers and helping train them, for cooking meals and fixing vehicles. And you kind of have to be a jack of all trades and a master of none. And at the same time, you have to be extremely adaptable to the patients, because this is something that is important in all of our clinical practices, is to be extremely adaptable to our patients. But it takes on a different level when you're in a country where you don't really understand the culture, and you have to spend more time really understanding patients, adapting to their culture and their customs and their beliefs. And so the clinicians that arrive to do this sort of work are actually quite remarkable people, and they all sort of step into this role and adapt and do amazing work. And so for me, the clinicians are like the lifeblood of our organization, and they're some of the most amazing people I've worked with, because the challenges that they face are really unique, and the type of person that's attracted is a very unique person as well. So that's kind of their role. And in each country, the scope of practice is going to vary depending on how the healthcare professionals perceive us. So in Botswana, it was really interesting because sometimes doctors are asking us, why don't you prescribe medication? It just saves us a lot of time. Why don't you just prescribe medication? We have the right to order and interpret MRIs and CTs and X-rays in Botswana. Now, we also have background assistance in that. So John Taylor was somebody that who has helped us for a long time to interpret images if we're not sure of things. And so we always have this background of clinicians that we can turn to if we need any support. And in Botswana, when there was a patient I wanted to treat who I felt like a local anesthetic would be helpful. And the orthopedic surgeon said, well, why don't you just book a theater? We should put them under general anesthetic. So I was able to just book a surgical theater to do a manipulation under anesthetic. So, of course, I was doing it with an orthopedic surgeon and with a team, but we're sort of given these opportunities that we wouldn't have elsewhere. And in Botswana now, Dr. Stephanie Eberspecker, who's running the program there, has been asked to come in and help out in surgeries. So we're seen as real experts in spine care, and the other healthcare providers really respect our knowledge and our experience and our abilities and want to incorporate us more. So it's the same with blood tests. They want us to be able to, they say, well, just order the blood test. And if our clinicians aren't comfortable with interpreting blood tests, they'll just sit down with the doctor and say, okay, well, what's going on with this blood test, and what's the significance? So in Botswana, we're given a lot of privileges, and we obviously take them very seriously. And if it's anywhere outside of our regular scope of practice or expertise, we do this in conjunction with the doctors or the surgeons. So the scope of practice, like I was saying, it's going to vary a little bit depending on where we are. But that's sort of an outline of the life of a clinician.
Yeah, and I'm sure the patients that you see are probably different than the ones that you see in Ottawa currently. Can you just give us maybe a couple of glimpses into what kind of conditions the chiropractors would see there?
Yeah, it's interesting because the vast majority are still general musculoskeletal pain without red flags, without neurological symptoms. That's still the vast majority. But what we found when we looked at our data registry is maybe in my practice in Ottawa, I might see maybe a 1% pathology. Because, again, in North America or other high-income countries, chiropractors they're not the first contact. And so patients have sort of been through the healthcare system and landed on your doorstep, and they've already been screened for red flags and everything else. So probably might even see less than 1% pathology. Whereas in Botswana, it was more around 10%. And so we've seen some really interesting stuff. So dens fracture, and these are things that we actually diagnosed, not just patients presenting with these, but we actually diagnosed rheumatoid arthritis, polyneuropathy, fractured dens, situs inversus, Sprengel's deformity, Klippel-Feil, tuberculosis. We actually wrote a case series about tuberculosis from Botswana. Hydrocele, metastatic bone tumors, gout, rib fractures, myositis, HIV, jaw fractures, Paget's, type 2 diabetes, Blount's. It goes on. So
Yeah.
the amount of pathology there in a very short period of time is way more than I have ever seen in 15 years of practice in Ottawa.
Wow. Now, do these patients get care provided for free?
Well, in Botswana, they pay, I think it was 5 pula, which I think is about the equivalent of 25 cents. That's if they go to the hospital. So they walk into the hospital, they pay 5 pula, and that gives them access to everything. And that's imaging, X-ray, CT, MRI, gives them access to medication, any doctor they need to go to. So the Botswana healthcare system itself is quite remarkable. Now, we ourselves do not charge at our clinic. So if people are walking directly into us, then they don't pay any fees. Dominican Republic patients, if they cannot afford care, then they can apply for exemption on that. So what we're trying to do is we don't want any barriers to care wherever we have a clinic. We want people to be able to access it no matter what their income level. But we have had to negotiate that in certain places. So in Dominican Republic, anybody who can't afford it still gets care, but those who can afford it do pay. India, it's all free. And Ghana, I think it's a minimal fee as well. It's not very expensive, and they again can apply for exemption if they need it.
Okay, great. Thanks for going through that. Now, how can chiropractors get involved in World Spine Care?
There's multiple levels. So we need help at all levels. And let's say if you're a clinician and you want to head off into the field and either gain some experience or spend some time. I mentioned earlier the 2 different levels, and one is the volunteer associate. So with a volunteer associate, you pay your own way for everything, but once you hit the ground, your accommodation is free because we have residences at all our clinics. You just pay your own food once you get there, and then for any holiday travel you want to do. But you've got to get there, and you've got to cover your own health insurance and things like that. And that's anywhere from 1 month to 3 months. If it's any less than 1 month, it puts an extra burden on our clinic supervisors without really a payoff at the other end. So we ask that people commit to a month, or in Botswana, it's up to 3 months, because past 3 months you have to apply for a special visa. So that's a real hassle that takes a lot of time. So if you're going to stay extra time and you're going to go through that hassle, then that's where the clinic supervisors come in. And the clinic supervisors spend a year at the clinic or more, and their expenses are covered. And then in some locations, they're actually on a bit of a salary. So in Botswana, the Botswana government is covering all our expenses and actually paying salaries to our clinic supervisors right now. And so there's actually a bit of a salary for those if you're staying a year or more. Those are the 2 ways to get involved as clinicians. Now, there's also enormous and endless research opportunities. And we've had researchers coming and collecting data for all sorts of things, from students from, one from CMCC went down to Dominican Republic, a couple from Durban University of Technology came and did research in Botswana. We've had we have a student from the University of Southern Denmark doing some work right now. Maria Hondras did all her PhD papers in Botswana with University of Southern Denmark. And then we have the World Spine Care research, which is not driven by students, but is driven by our research team. And so we have all of these opportunities for research. So anybody who wants to get involved with research with us, please contact our research team. So there's all kinds of opportunities there. And then we're always looking for help with fundraising and marketing and other stuff, and just spreading the word, just telling other people about what we're doing and getting them excited about it, and participating in some way and helping raise awareness and funds and stuff is absolutely fantastic. So that's another way people can get involved if they can't actually, get out of their clinic and get on the ground. We do have on our front page this Work a Day for World Spine Care, and you can click on that and get information that will allow you to, it gives you posters and information for patients and stuff, and actually spend a day raising funds for World Spine Care. So there's all kinds of opportunities in that way to get involved.
Yeah, perfect. So the next thing that I wanted to get into, and you provided a nice segue into that, is the research that's done through World Spine Care. And I guess for listeners, an easy place to learn about all the current research is through the European Spine Journal in September of 2018, dedicated the entire supplement to World Spine Care and the Global Spine Care Initiative. And Dr. Anthony Wolf wrote an editorial that I actually am just going to quote and read verbatim, because I think it really sets up World Spine Care in general, but care to underserved communities quite well. So he says, the Global Spine Care Initiative is an ambitious program based on need, enthusiasm, commitment, expertise, and evidence. We still need more knowledge. In particular, we need a fuller understanding of spine-related disorders within the ethnically, culturally, and socioeconomically diverse populations of low and middle income and underserved communities. We also need to know whether Global Spine Care Initiative approach does make a difference in such populations. We need to test and learn collecting data to establish whether implementing such a program makes a difference. These efforts must use outcome measures relevant to people in these countries and communities. In a time of limited resources, we have to demonstrate a return on an investment being made by society, and most importantly, by people with spine-related disorders. And I'll just make a couple of other points, and we'll get into some of these, or at least one of these papers here. So a couple of points to really drive home the idea, I think, is from the Lancet papers. We know that disabling low back pain is overrepresented among people with low socioeconomic status, and disability and costs attributed to low back pain are projected to increase in coming decades, in particular in these low-income and middle-income countries where health and other systems are often fragile and not equipped to cope with this growing burden. And so I think this is the exciting thing about World Spine Care and the Global Spine Initiative. So let's talk perhaps about the first paper that came out of this, which is kind of a general, overview of World Spine Care. So I don't want to repeat what we've already gone through, but maybe you can just give us the highlights of this first paper in the supplement. So it's the Global Spine Care Initiative, World Spine Care Executive Summary on Reducing Spine-Related Disability in Low and Middle Income Countries. So Geoff, if you could maybe just hit some of the highlights of that paper, that'd be great.
Well, let me instead, because I think a lot of your listeners may not be aware of the Global Spine Care Initiative or read the papers yet. So maybe a little bit of an overview of the whole collection of papers.
Yeah, perfect.
If you think about, I read this book, Essentialism by Greg McKeown, and he talks about trying to find your highest level of contribution. And I think that, as a profession, we should be thinking about, well, what is our highest level of contribution? And that is where there's going to be the greatest need and the least access to care. And we all know now that the highest need is in the low and middle income countries. And that's also where we have the lowest access to quality spine care. And this is, the Lancet was a call to action to address this problem of back pain in low and middle income countries. So the response to this call to action is sort of what World Spine Care and the Global Spine Care Initiative are doing. So starting with World Spine Care, what we did was we got on the ground, we worked out a lot of problems to provide, experience in providing care in different countries, cultures, level of resources. And within that, we created patient-reported outcome measures for low literacy populations. We created the toolkit and the data registry that I talked about. We're working on sort of awareness and prevention programs. We started a yoga project for prevention and management and community engagement, education programs that I spoke about. And then we gathered the tuition scholarships and support from the chiropractic colleges. We hosted the conferences, and this is all the stuff we kind of have been doing in the background. But we still don't have this comprehensive evidence-based program that we can roll out across the country, nationwide, and through all levels of the healthcare system. We're basically treating patients in the clinic, and that doesn't really have enough of an impact, treating patients one at a time as they present to the clinic. We're only really providing care at one level of the healthcare system, which is very important, and it's a great starting point, but it's not going to really tackle the problem of spinal disorders in developing countries. And World Spine Care's vision is a world in which everyone has access to the highest quality spine care possible. And to achieve this, we really need to take what we're doing and expand it. And I think for the greatest impact, we have to have this model of care and this program that's implementing evidence-based care from the very most remote healthcare outpost all the way to tertiary care hospitals and everything in between, and all the way from education, prevention, and awareness programs all the way, again, through to highly specialized tertiary care and spine surgery. That real full spectrum. And I think you mentioned this before. The question is, well, what should we be bringing to these low and middle income countries? And sometimes when we talk about this World Spine Care program to healthcare institutions, we kind of get this feeling, and it becomes clear that what they really want are these high-cost diagnostic and surgical facilities, because that's seen as our healthcare system is evolving and we're successful and we're now becoming modern. And they really wanted what we had in these high-income countries. But we know the model of care in high-income countries is not what we should be bringing to these low- and middle-income countries. And we can't just consider, well, what should we be doing, but what should we not be doing? And really, evidence-based spine care is not really sexy or flashy because it doesn't involve this sort of high-cost diagnostic and interventions. But some institutions, like the Botswana Ministry of Health and Wellness, really embrace the World Spine Care evidence-based, integrated, sustainable approach. And one of the key figures in Botswana was Shanaz El-Halabi, who was the deputy or the permanent secretary to the Minister of Health, and she's the one who wrote the introductory letter in the European Spine Journal supplement as well. And she really saw the vision, and so Botswana was really an awesome place to open this up. So the Global Spine Care Initiative is really the first attempt to create this kind of comprehensive model and strategy for the delivery of the highest quality spine care possible. And it's also, as you mentioned before, this is a model that's relevant for high-income countries and their healthcare systems. It's not like we're creating something different from low and middle-income countries. The Global Spine Care Initiative is creating something that's relevant to all countries, no matter what the income level. But what's great about the Global Spine Care Initiative is it gives information in how to deliver quality spine care in countries with different levels of resources, and that's where it's also a little unique. Is it helps us figure out how do we do this in a high-income country and how do we do this in a low middle-income country? How do we do this the very front line in the remote village with nothing but a few nurses, all the way down to a really high-end surgical facility? And you have to recognize that the Global Spine Care Initiative, this is a starting point, and it's where World Spine Care has to now take this model and care pathway and so on and implement it and test it and modify it so that it actually becomes even more functional, and test it and do the research around it. So that's kind of the overview of how World Spine Care and the Global Spine Care Initiative kind of fit together. So now you want me to do an overview of the Global Spine Care Initiative?
Well, that would be terrific. If you could just do a brief synopsis, because I wanted to ask you about the care pathway as well.
Okay. Well, let's fit that into the overall overview. So what happened is there are 9 foundational articles and 4 consensus-based articles. So the 9 foundational articles, the first 2 were about the burden. This is the problem we have. And then the next 7 articles were about interventions. What do we actually do to, like, what are the evidence-based interventions? And they come into the categories of what's evidence-based assessment, when we should and shouldn't use diagnostic imaging and other tests and so on. Then non-invasive management, invasive interventions, and then there's a surgical care stratification, non-invasive for compression fractures, psychosocial issues, and then prevention and public health. So those are the foundational articles. Then the team of collaborators, researchers, clinicians, and so on, got together and created these 4 consensus-based articles. So number 1, how do we classify spinal disorders? And then within each of those classifications, let's take that intervention information and put it into a care pathway. So for each class, when a patient comes in, you put them in the class, and then you can see what are the evidence-based interventions, well, assessment, intervention, and psychosocial issues, and so on. And that's been created into a set of flashcards, essentially, that can be, we can build a training program around and offer these flashcards and training around it so that everybody from frontline all the way to tertiary care knows at least what evidence-based interventions, what are the evidence-based interventions for each of these different classifications. So we have the classification, then the care pathway, then the resources. How do we, what is needed on the ground to be able to offer evidence-based spine care, and then what are the main principles and implementation of the program. So I think the real important ones for the average chiropractor is classification and then care pathway.
Gotcha. So, yeah, why don't we get into that? And that's a specific paper, Global Spine Care Initiative Care Pathway for people with spine-related concerns. And I'm not so much as interested in getting down to, all the methodological issues, but if you could just give us your perspective on how you've gone about implementing these programs and how does it happen, that would be terrific.
We implemented, like what we've done on the ground is we've implemented what we thought was the best evidence-based, sustainable, integrated program that we could offer. Now we have additional knowledge from the Global Spine Care Initiative that's going to further direct us. So how we implement a program, or how we have, is bringing that primary spine practitioner and setting up primary contact clinics within the healthcare system. And then that volunteer, that clinic supervisor who's on the ground is not just running the clinic, but also now starts to kind of get the lay of the land, figure out what's needed, who to contact, who's going to be the support, where to find funding, and so on, so that the program can kind of expand out in both directions from that primary contact, so out into the rural communities, and then also towards the tertiary care as well. And so to take a comprehensive model and approach a government system and say this is exactly how we're going to implement it in your country, I think would be a little bit overwhelming and extreme amount of cost and resources. But to start the way we've gone about it is gone in small and expanded from there as we gather more and more information. So that's kind of how we have implemented it. But obviously that as we gain more knowledge and experience from the Global Spine Care Initiative, following this approach, that's probably going to shift and change. But up to this point, it's worked, and we've gained a lot of support from all the governments that we've worked with. And so right now, with our toolkit, with this new pathway, part of our job is going to be implementing this new pathway within our existing toolkit, and then creating education programs around those.
Okay, terrific. So, Geoff, what's it like being a clinician researcher on one of these multidisciplinary world spine care teams? I know you have participated in this research, and I know you have strong feelings that clinicians should be a part of the research, but just give us some perspective on that.
Yeah, it's awesome. It's absolutely amazing to be a part of a team of some of the leading researchers in spine care around the world coming together and being able to participate in that, not having as impressive a research background, but coming more from the clinical point of view. And our research team has a lot of clinicians on it. We always have our current clinic supervisors in the field are always part of the research meetings. And then we always invite researchers to our clinical meetings as well. So when we're making decisions on modifying or updating our toolkit, we can have a researcher in the background kind of going, well, I think this is a better way to do it, or this is a better way to do it from the data collection point of view. And then when the researchers are saying, well, we want to do this and this and this, our clinicians on the ground are saying, okay, if you want to do it this way, we've got to modify this. This can't be done. We'll have to change that. And so the collaboration, sometimes it gets pretty heated in the meetings, which is a good thing. But in the end, I think the quality of the research and the quality of the data collection is really good when the clinicians are really brought into the research world and given a clear understanding of what the researchers want to do, and then the researchers really have a clear understanding of what the clinicians are doing and what is and is not possible on the ground. And that's why I think that every research team should have clinicians on it, and every clinical team should have researchers participating as well. And a lot of the researchers we have on our team have amazing backgrounds in every area imaginable.
Yeah, most definitely. It's a kind of a dream team of researchers. Fantastic. One of the things you had mentioned to me before the call today was that you had to develop some novel patient-reported outcome measures. I'd be interested in hearing a little bit more about this.
Yeah. So when we got on the ground, we tried to use existing patient-reported outcome measures. And we had a unique situation, and that is, number one, low literacy. So you can't use words like, we couldn't use words like depression or anxiety and try to translate it and explain it to somebody. We couldn't, sometimes the questions asked about vacuuming or even getting on a bus or stepping onto a bus, which some people might do, but not in these areas. So we found after a while, we kind of made the decision that there's just nothing out there that really was working for us. So we had to try to create this novel patient-reported outcome measure, and there were two things. Number one, we didn't want to have a patient-reported outcome measure for every part of the body because that just creates a nightmare in the clinic. We wanted to try to create a patient-reported outcome measure that could be used for every body part and was very simple and straightforward, and patients would understand, and could be used across different cultures and countries. So already I'm sure you're thinking, well, that's impossible. And we're not sure whether it's possible yet because we actually haven't done a validation study on the patient-reported outcome measure. But those were the requirements. That's what we were looking for on the ground. And we created something that seems to be working, seems to be responsive, but we still need to go through a proper validation study to find out whether it is a good patient-reported outcome measure. But that was really challenging because sitting down with patients and trying and actually talking to the patients and saying through an interpreter, saying, how did you feel about answering this questionnaire? How did you find this difficult? Did you understand it? And I'll never forget sitting with this elderly woman who had less than a primary education, and she was sitting down, and I was just trying to ask her about how she felt about the questionnaire and whether she understood it. And tears started to well up in her eyes, and she didn't know what to say. And finally, through the interpreter, the interpreter said, well, she really doesn't understand why you keep asking her questions. When she was at school, when she was a very young child at school, if she didn't know the answer, the teacher would just go to somebody else and ask to get an answer. Why do you keep asking her the same question? And I hadn't been asking the same question. I was trying to ask it in different ways. And so I had to explain to her that I really was interested in what she had to say, and try to make her understand why her feedback was so important to us. And eventually she relaxed and started to tell us. But we went through that process with a lot of patients to try to see what worked. And the patient-reported outcome measure kept having to get stripped down and stripped down and stripped down to something simpler and simpler and simpler. So that's been a really unique challenge, and I'm really looking forward to that validation study to see if this is something that actually is whether it works.
Yeah, well, I can tell you that there's spine care folks out there all over the world that would appreciate a stripped down version of what currently exists, because there is an outcome measure for this, for that, and there's so many outcome measures, and they are rather complicated, and sometimes they ask pretty explicit questions that don't pertain to people, and so a nice, clean, simple outcome measure would be fantastic. I'll just speak for myself, anyways. I would appreciate it.
Well, it's speaking to me too, which is why I think that the average clinician in the average private practice doesn't use outcome measures. They don't, and I think it's just because they just don't work. They're too burdensome. They're too cumbersome. Some people do for particular. So some people use start back for low back pain. Great. Or Bournemouth. Great. But what if they come in with shoulder pain? What are we going to use? And what if they come in with knee pain or ankle pain? Like, how do we have this jumble of all these different patient-reported outcome measures? So you may find clinics that will use one particular one for one body part, especially if it's a real spine-focused practice. But for the general clinician, I mean, I treat everything from head to toe. I can't use, if I used just the start back, it'd only be a smaller percentage of my patients that this is relevant to. And then asking a patient to repeat outcome measures, because outcome measures we repeat them, and the patients fill them in after each of the first 3 treatments, and then every third after that. Because a patient-reported outcome measure is not as useful if you give one at the beginning and then one at the end of care. The patient-reported outcome measure really needs to inform the course of your care. And so it needs to be applied at a repeated basis so that the clinician can find out, are things really actually getting better, and then use it for an overall outcome measure. So again, it's these sort of ideas we've had to play with and grapple with and try to figure out in the field.
Sure. Yeah, fantastic. Well, Geoff, one last question here, and I ask this of all of my guests. And in your situation, it's very unique because you're primarily a clinician, but you've had experience in the administrative sides, talking with governments, and certainly doing research. So I'm curious to hear about your experience with research and what advice you'd give to chiropractors or students who might wish to pursue research careers in chiropractic science.
Great question. And I always like hearing what other people say in your podcast. And I think, for me, it's a little different. I like to be a jack of all trades and a master of none. That's sort of been my life mission, I think. And I like teaching, but I don't want to be a full-time teacher. I like the clinical work, but not a full-time clinician. I like research, but not a full-time researcher. And so I've had this opportunity to be a clinician and do research. So I think that sometimes clinicians are like, well, I'd like to get involved, but I don't really want to do a PhD, and I don't want to do a master's, and so I don't really know how to go about it. And I think looking for those opportunities where you can participate in existing research is a really great way to kind of get your feet in, to be a clinician and also to be part of research but not driving it, not doing the PhD or master's yourself, but participating and helping out. So a lot of the data registries that are popping up, like Spine IQ and things like that, to participate in those types of things, to be a part of that research, and find out if you like it. You can always go further into it, but being on the periphery and having it just sort of part of your clinical practice, collecting your own data and playing with it, anything. But you don't have to jump in head first and feet first and kind of be a full-time clinician or full-time researcher. And I absolutely love it. And we're always looking for extra people to help out with research. So, you can always contact our research team and see if there's any way that you can help out.
Yeah, terrific advice. And I would just echo the comment about clinicians getting involved, and you don't have to be full-time. I can just speak for our program that we're typically always looking for researchers to help with projects in the field. So yeah, absolutely. There's so many different ways to do it. So I'm really happy that you mentioned that as an option. Well, I really appreciate you coming on the podcast today, Dr. Outerbridge, and talking about World Spine Care, the Global Spine Care Initiative, and your practice and your research experience. Is really valuable information. So thanks again for coming on.
Thank you very much again for the invitation, Dean. It was a lot of fun.
Thanks again for listening to the Chiropractic Science Podcast. This episode with Dr. Geoff Outerbridge, where he told us all about World Spine Care and the Global Spine Care Initiative. We look forward to bringing you more podcast episodes coming soon.